Thank you for introducing me. Assalamu alaikum and very good afternoon. Dear learned audience, this topic has already been discussed by our two previous presenters, and I am the last one to talk on this topic. So let's see what's new information here. So let's recapitulate about the basics of ctDNA. It is basically a small fraction of cell-free DNA which is derived only from the tumor cells. And if you see on this slide, you can see that the most important information is the half-life, which is about 2 hours. And ctDNA is like finding a needle in a haystack. So we all know that there are two categories of ctDNA assay. One is tumor-informed assay, another is tumor-agnostic assay. So in tumor-informed assay, you have tumor tissue in your hand, either from biopsy or from surgical resection. So first you have to sequence that tumor tissue to identify specific mutation, like KRAS mutation is present in this tumor. And later you have to track down that KRAS mutation in the circulating tumor cell. So it is more tumor specific, and it is usually used to identify minimal residual disease. It is more personalized and more customized and tumor-specific assay. On the other hand, in tumor-agnostic assay, no available tumor tissue in your hand. So you have to do broad-based panel, like full colorectal panel, to identify any mutation is present or not in the circulating tumor cell. So it is not tumor-specific assay. And it is usually used to identify any recurrence disease or resistant disease or any appearance of the new primary lesion or any metastatic disease. So it is not tumor specific and not personalized or not customized. And these two assays are done by Guardant Reveal, Signatura, SafeSec or digital droplet PCR assay. Now why we are concerned about the ctDNA? Is it only for discussion or has it some clinical implications? I think we are all waiting for this slide. So let's see. So ctDNA can be used for screening and early detection of colorectal malignancy. It is also used in diagnosis of colorectal malignancy, especially when patient is frail and biopsy is contraindicated. Also for confirmation of diagnosis when there is doubtful histopathological report. And the most important information here is to identify minimal residual disease, which is usually done 4 weeks after surgical resection or completion of adjuvant therapy. It is also used to identify any recurrence or resistant disease or to identify subclinical relapse. By this way, it helps in prediction of prognosis. And moreover, it helps in assessing the response to treatment, like new adjuvant treatment. And by this way, it helps in selection of candidates for WW policy. And also the most important point here is that it also helps in decision making in stage 2 colon cancer with deficient MMR. I will talk on this topic later on. And it also helps in selection of targeted therapy in case of metastatic colorectal cancer. And in a patient who received immunotherapy, there is a question when to stop the immunotherapy or should this patient continue immunotherapy. So in this regard, ctDNA also helps. And finally, ctDNA helps in detection of intra or intertumoral heterogeneity and monitoring of clonal evolution. So let's see this case capsule. This is the most common clinical scenario we frequently face in our clinical practice. So this is the stage 2 colon cancer with deficient MMR and no bad prognostic factor is present here. So in this case, what do you think? Does this patient need any adjuvant chemotherapy? Yes or no? So we are really get in trouble while deciding for adjuvant chemotherapy in this case. And in this regard, we can take help from ctDNA. If ctDNA becomes positive after 4 weeks of surgery, then this patient usually needs adjuvant therapy. But if ctDNA becomes negative, then this patient should go for close surveillance. So from this slide, we can say that in ctDNA guided approach, we can precisely select patients for adjuvant therapy without compromising 2 years recurrence-free survival. Now let's look at some important points regarding the ctDNA. So if you see this curve, you can see that the blue line indicates the detection level by conventional imaging, and the red line indicates the detection level by ctDNA. So from this graph, you can easily say that ctDNA detects tumor earlier than conventional imaging, and the median lead time is about 11.5 months. So this is the lead time. You can clearly see that ctDNA detects tumor earlier, which is about 11.5 months. And another important information here is that in stage 3 colon cancer, after completion of adjuvant therapy, if ctDNA becomes positive, then this high-risk patient may need second-line chemotherapy. And from this picture, you can clearly see that the detection rate of ctDNA in different stages of colorectal malignancy. So in stage 1, the detection rate is 0%. In stage 2, detection rate is 7 to 10%. Stage 3, it is much higher, 13 to 15%. Stage 4, it is much more higher, it is about 75 to 85%. So from this picture, we can clearly say that in early stage colorectal malignancy, detection rate of ctDNA is very low. We have to personalize while deciding for investigating this type of assay in patient. As ctDNA is a very costly investigation and it is not available everywhere. We have to select which patient really needs ctDNA assay. So another important information from this slide is that ctDNA helps in prediction of recurrence-free survival. If there is elevation of ctDNA methylation of SOX11 gene, it indicates reduced recurrence-free survival after curative intent resection of locally advanced rectal cancer. Now we will see some studies and we will look at what these evidences show. So this is a study on neoadjuvant chemoradiotherapy in a patient with rectal cancer. So in the study, you can see that ctDNA is an indicator of tumor burden. So they have done ctDNA in 4 time points. So in this graph, we can see that this is the baseline ctDNA level, much higher, and during neoadjuvant chemoradiotherapy, it is a bit lower. And after completion of neoadjuvant therapy, the ctDNA level is much more lower. That means this tumor is responding to treatment. And after completion of surgery, the detection rate is almost goes to baseline. So by doing serial ctDNA assay, we can clearly assess the response to treatment. And if baseline ctDNA level is higher, then it indicates that distant metastasis within a shorter period of time than ctDNA undetectable level. This is another study on neoadjuvant chemoradiotherapy in a patient with locally advanced rectal cancer. So let's see what shows. So in this study, we can see this curve, And we can say that ctDNA can supplement MRI to better predict neoadjuvant chemoradiotherapy response. And thus it helps in precisely select patients for non-operative management. And in this graph, you can see that the sensitivity is much higher if you combine ctDNA and MRI. This red line indicates the combination of ctDNA and MRI. And this is the ctDNA only level, and this is the MRI only. So the sensitivity is much more higher if you combine these two tests. And this is another study on resectable colorectal liver metastasis. And from this study, you can see that in resectable colorectal liver metastasis, ctDNA helps in personalization of patient in perioperative chemotherapy or adjuvant chemotherapy. So if baseline ctDNA level is positive, then this patient usually needs neoadjuvant therapy or perioperative therapy. But if baseline ctDNA level is low or negative, then this patient usually needs adjuvant therapy. And if both pre and postoperative ctDNA level are negative, then in this subgroup of patient, usually adjuvant therapy may be shortened or may be omitted. So from our today's discussion, what should be the take-home message? So let's see. ctDNA is recommended in routine clinical practice for treatment decision, especially when tissue biopsies are not available or when faster results are needed. Comparing with CA and CA99, ctDNA showed to be a much more sensitive marker in monitoring the tumor burden and in predicting the prognosis. ctDNA can be incorporated into routine follow-up to complement the CA test and radiographic imaging for earlier detection of relapse. These are the references. So thank you for your kind attention.